women's health issues with regards to how she might be able to assist people, assist women who've had children and potentially maybe having some pelvic floor weakness issues or potentially even undiagnosed prolapse or low stage prolapse and things like that. But Pip is a women's health physio specialist, which is why we've got her to come and have a chat. And Pip, I'm going to throw over to you and let you have a chat to us and run this the way that you'd like to run the next little hour or so.
Cool. So my background is that I initially started training to be a physio for the ATP tennis tour and did some work with some of the elite players, and then I got cancer, and that then took me down a different field of women's health. So since then I've done heaps of sport, and in the clinic I do mostly the really complex chronic spinal stuff, where people have, like 15-year histories of pain and very complicated injury histories. And I do a lot of the complex women's health as well. So basically my predominant work is currently in spinal and women's health. So you can throw whatever you like at me that way. But also if you have the sporting questions, we can do that as well. And obviously also then I have a background in treating oncology patients as well as being one. So that aspect of women's health, if you want to throw those questions my way, you can go for it as well. So we can do this a couple of different ways. It's really entirely up to you guys. Like some of you will have questions that you want to just throw out at me, and that's totally fine. And other people will have questions they don't necessarily want everybody else to know that they've asked. So you can send them through in the little chat box. You can send them through privately and I can see them and I'll answer them as I can. But if you want to just shout them out, shout them out. So it just depends, like, does anyone have anything in particular that they would like me to cover? And then I can do that, or you can just throw questions at me for an hour, or I can just give you a rundown of how the body works. So it's entirely up to what the majority would like.
Hi, Pip. I might ask you a question if that's okay. My name's
Avril. Go for it.
So I'm one of the Refresh You trainers as well, and I know that a lot of women have some, I guess, difficulty understanding at what point should they seek out some help, with regards to say pelvic floor issues.
In terms of immediately postnatal or more down the track?
More down the track. So a lot of women will just get on with it and just go, oh, it'll be fine. I'll kind of ignore it and it might go away. So at what point, at what stage do you recommend that they, come and see somebody like yourself, or come and get some sort of help so that you don't make things worse for, later on?
Pretty much at any point. So what the statistics show is that 92% of the women who are experiencing some incontinence postnatally, so whether that be a little dribble here and there, or you leak with a cough and a sneeze, or whether it's more with a full bladder and exercising, or at any point, 92% of those women are not going to see any improvement in their symptoms within 12 months or 5 years unless they get intervention. So basically, if you're postnatal, we recommend that you actually have a postnatal check, because your body's been through an enormous amount of change in 9 months, let alone post-delivery. And then in terms of later in life, there are a couple of key times we like to see people, just in terms of general well-being checks, even if they are not symptomatic of anything. So we like to see young women if they have heavy periods that are really painful, that are often a little bit irregular, and if they also have anemia, that tends to be indicative of them having endometriosis. So what we tend to find then is, particularly if they've already become sexually active, then what happens is they'll have pain with sex, and sometimes they won't be able to do it, and that can be a massive symptom of endometriosis. So if we can pick those women earlier, then we can get them treated for the endo, and then the endo is not so bad and it doesn't affect their fertility as much. Then we like to see women prenatally. So in an ideal world, you see them before they're pregnant, so you can prep their body as much as you possibly can, get their alignment as good as possible, check what their pelvic floor is like, because once they get pregnant, you have to wait a period before you can do an internal check. I mean, if someone's sexually active, there's no reason why you couldn't do an internal check, but it's just safer to wait till they're a little bit further down in their pregnancy. And then we most definitely want to see almost everyone postnatally. I can't think of a reason why we wouldn't see someone postnatally, except for the fact that, you know, they might not be coping, and so, you know, they got other things happening. And then the other time we like to see people is around the perimenopause menopause time, because there's a huge amount of things that can then change, and your hormones play an enormous role in how well your pelvic floor functions, how well your core functions, how well your digestive system functions, what your abs look like, all of those sorts of things. So often we find there's quite a lot that we need to intervene at that point. And sometimes it's just a matter of, hey, things are starting to change a little bit, you might need to tweak this and that. And sometimes you can actually find some really significant changes in people that are obviously better found earlier rather than later. So they're probably the main times we would hit people. But if you're symptomatic, like, the advice would be to go and be seen immediately.
Yeah, I mean, yes, if you're having sort of like definite problems, but I guess, you know, I imagine a lot of women have what they would sort of say is a slight problem, or, oh, I don't really have a problem, it's only when I sneeze, or it's only when I, you know, jump around too much, or it's when in fact they actually should go and get checked out to stop any sort of anything getting worse then later.
Yeah, there's a lot of women who haven't had kids who have continence issues, whether it just be you've gone to the bathroom, you stand up and then you get a little dribble afterwards, or a feeling of heaviness, or even back pain can be your only symptom, or hip problems. So because the pelvic floor goes from hip to hip, if something screwy is happening in the pelvic floor, you can end up with hip problems really quickly, which can obviously then lead to knee problems, back problems. So it's kind of one of those things that can really affect your entire body function. So even if you're just getting like a drop here and there, or sometimes sex is uncomfortable, but only in some positions, like, I would still get it checked, because it's much harder to treat if it's been there for 30 years rather than if it's only been a problem for, you know, 12 months.
Yeah. Cool.
Like with everything.
Yeah.
Okay, so then I've just got someone sent through a question. Okay, so someone's asked about change in bodies, so I presume body shape and body weight during menopause. So we can cover that. So with the pelvic floor, unfortunately, there is a relationship between your size, so your BMI, and the likelihood of developing prolapses and incontinence, and it is a bit of a vicious cycle. So what you tend to find is that because of hormonal changes, it is much harder for women to shift weight around menopause, and very, very easy to add to your frame. Similarly, postnatally, women are also generally a different shape to what they were prenatally. And what tends to happen is they experience a bit of leaking with exercise, and then that puts them off exercising. So then their body weight goes up, which then makes it even more likely that they will have a prolapse and leaking when they go back to exercise. So then they stop exercising again, body weight goes up, and you just go round and round in this circle. And so body weight does impact your pelvic floor function. So it is something that we need to address in some people, but sometimes, like, there are actual hormonal reasons why people really struggle to lose weight. And obviously people have different bone densities, different shapes, and like, not everyone is capable of being a tiny size 0 like model body. So you know, there is aspects of that you've got to look at. So sometimes we need to refer people for blood testing if they're struggling to lose weight, because thyroid can go out around menopause and around giving birth times. So sometimes whether your thyroid is functioning well will directly relate to how well your metabolism is working and therefore your body shape. So hopefully that's answered that question. If not, you can flick it to me a little bit differently if there was something else you wanted me to cover. So prolapse, and how likely are you to have a prolapse? So with everything, there is a genetic component, but a lot of prolapse comes down to how well you control your body alignment, what your muscle strategies are like. So a lot of the time when I do a pelvic floor assessment, if I ask someone to show me what they think a pelvic floor exercise is, they're often pushing down rather than lifting up, and that's about half the time. So if you're pushing down all the time thinking that you are stabilizing, then you're more likely to create a prolapse because you're bearing down and actually physically pushing things out. The same if you have chronic constipation that you don't treat and you're always bearing down. Again, that increases your likelihood of constipation, which then brings in diet. And is there any reason why you're chronically constipated? Which can also be that you have a tight pelvic floor muscle that isn't relaxing, and so you can't let the bowel motion out, and therefore you become constipated. The other reason why people could have prolapses or be more inclined to have prolapses just in terms of the pelvic floor. So if you guys think you've got, as a woman, you've got 3 passages. So you've got your urethra, which is your pee pipe, you've got your vagina, and you've got your rectum, which is where your bowel motion comes out. That all fits within your pelvis, and there's a pelvic opening that looks, I'll get my head out of the way, like this. So on some women, when they bear down, that really opens up. So the larger that space opens up to, the more space that allows for an organ to fall down and through it. On other women, their natural shape is that it stays really small. The smaller that is, the less space there is for a pelvic organ to basically make a break for it. So the less likely they are to have a prolapse. All women have, because of the makeup of our anatomy, have unfortunately a reasonable risk of a small prolapse. It's about 40%, maybe 33. I haven't looked at the most recent stats this year, but it's a decent chance. The biggest measure of whether you're likely to have a prolapse, if someone in your family has had a large prolapse, is to go to the women's health physio and they measure you and they see whether it widens. And if it really widens, then sometimes you might then modify the exercises that you're doing to either improve your technique or change the way your muscles are firing while you're doing that exercise. Or sometimes if it like really opens and you really want to do high intensity exercise, then we can recommend a pessary, which is a little bit basically like a sports bra for your vagina. And you put a pessary in and different shape for different body, and it basically provides scaffolding support for your pelvic organs so that the ligaments aren't on as much strain, because it's when you damage those ligaments that the pelvic organ is likely to come out, and they would also check your pelvic floor strength to make sure it's adequate for the task that you want to do. Hopefully that answers that question. Is it possible to have a prolapse and be unaware? Yes. So one of the main symptoms of a prolapse is back pain. So that could be your only symptom. So because, let me just see if I can find a nice picture. And then I'll just screen share it. So, okay, hopefully this works. I'm going to hit screen share. David, I think you might have to turn screen share on.
I probably do. Let me have a look. I might have to get my
don't worry about it.
IT manager to give me a hand here. She's just
all
walked
good.
in the
Don't
front
worry.
door.
So if this is your butt bone and this is your tailbone right down here, your back sits right on top of your sacrum, so your butt bone. And then your pelvic floor sits here as the base of the pelvis, and then your pelvic organs are in here. Something has to hold your pelvic organs in place. And so you have these little kind of like thick glad wrap connections that go towards the top of the butt bone. And so that suspends your uterus in place and holds it upright. If your uterus starts to head south, it'll pull on that ligament, which will pull on your butt bone, which will make you feel back pain. So you can feel things that way. Again, like I said, the pelvic floor goes from hip to hip. So if you have a really weak pelvic floor, you might be lucky and not have any like urinary symptoms or anything like that, but you might have hip pain as your only symptom, or knee pain because you have poorly controlled hip joint. And as soon as you have a poorly controlled hip joint, it affects your knee. So you could have what we call musculoskeletal signs. So basically you would go to a sports physio and say, oh, my back hurts or my hip hurts. And that actually be a pelvic floor that needs to be treated. There are plenty of times when I've seen chronic, really bad backs that have had surgeries and things like that, and they don't get relief until you treat the pelvic floor and help with the prolapses and put a bit more support into the body, whether that be by training the muscles properly or by sometimes putting a pessary in. Is joint pain related to menopause? Yes, can be. So changes in estrogen and progesterone can change your connective tissue. It can make things like, if you think of a plastic bag, so say you go to the supermarket and you get the, if your fruit and veg is wet, the plastic bag sticks together, right? So that's kind of what estrogen progesterone does to your urethra. And so as your estrogen progesterone balance changes with menopause, you get less stick. So the tissue starts to essentially not hold together as well. And that can be why people get leakage with menopause. And that estrogen progesterone change can also affect other joints. There is also the other hormonal changes that come with menopause. And sometimes then the body weight changes as well. You also tend to find that around menopause can be the time that other issues finally catch up with you. So what we tend to see a lot of is people that haven't rehabilitated their six-pack muscles after they've had a baby. And so they still have a separation, and most people focus on the separation width, and they think it's healed if the separation is as narrow as possible, but that's not actually true. And so what happens is they're not supporting their lower back and their pelvis because they haven't rehabbed that area properly. And then you start to see disc breakdown and things like that. Those things happen over years. It takes a disc a while to break down. So often by the time people are in the early to late 40s, you start to see them turning up at their physio with awful backs, awful pelvic control, terrible hips, because they've never corrected that postnatal posture. So, you know, when you like see people carrying a baby, they've got to push their hips forward, because it's like, if you ever tried to stand up really straight and hold a baby, it's not possible. You fatigue really, really quickly. But a lot of women stand in that position with their hips forward, and then they walk around like that for the next 20 years, and they wear through their cartilage in their hips really quickly. So there can be some of that, but obviously it also just depends what's going on hormonally that can cause a little bit of joint variation. And sometimes that can trigger people's autoimmune issues to flare up a little bit as well, which can lead to joint issues as well. Any other specific questions that anyone wants to throw out there?
My name's Richard. I'm the trainer at Pimble, obviously a male trainer.
All good.
So my question would be, let's say hypothetically somebody doesn't want to come and see you, doesn't want to get
pelvic floor exam. Yep.
What is there, let's say, would there be an everyday routine that somebody could do that's going to assist them manage things, let's say?
So it kind of depends what, are you talking pelvic floor?
Let's say pelvic floor, for example, yeah.
Okay, so if you're talking pelvic floor, the big first questions would be, to try and screen for an overactive pelvic floor. Because if someone has an overactive pelvic floor and you tell them to go and do more Kegels or more pelvic floor exercises, you are going to make things infinitely worse. So if someone has an overactive pelvic floor, and that this can happen at any point in life, and it can happen to blokes as well. So the symptoms of that would be pain on any kinds of penetration, whether that be a finger, a penis, a pap smear, a tampon, whatever. Again, comes with endometriosis very frequently, and sometimes also polycystic ovaries. When they've had a recurrent history of UTIs or thrush, very common. Little bit more common if you have autoimmune diseases, so thyroid problems, diabetes, things like that, but very common if you've had recurrent UTIs, recurrent thrush. Common postnatally when there's been tearing of the muscles, but the big giveaway then will still be generally pain on any kinds of penetration. And chronic constipation can be a giveaway for that. For guys, you can get erectile dysfunction, but there tends to be more prostate issues involved with men with overactive pelvic floors. So if they have any of those, particularly the pain on penetration, you wouldn't want to be encouraging them to do pelvic floors until they've actually been assessed. And you don't necessarily have to do that internally. You can do that with an ultrasound on their belly, and you can basically have a look at their bladder. And if someone's doing a pelvic floor contraction, it should lift, and then when they relax, it should drop back down. Often what you'll see on someone who has a tight pelvic floor is nothing happens, despite their very best efforts, because the muscle's already on and it can't switch on anymore. So then if you cue them to relax, sometimes you'll see it drop and then they're able to lift it back up again. So that can just increase your likelihood of suspicion that they should not be. But beyond that, if we're looking at general body who doesn't want to come in and doesn't have the pain symptoms, then I would wonder if you can cut off the flow of pee halfway through the stream with a full bladder. That would not be my method of training. That is a very quick way to get a urinary tract infection. So do not do it repeatedly. You can do it as a once off or once every so often to see if you can do it. And that also sometimes gives people a bit of an idea of what it feels like to do a pelvic floor contraction. You can get them to, like if they were in a gym setting, you get them to cup their hands around their pelvis and just do something simple like a leg lift and see if they can keep their pelvis from tilting side to side. And then you have a look at playing with core contractions and core cues and which one enables them to still have a soft stomach but have a neutral pelvis that's controlled. And then you can incorporate that into training. If someone was postnatal, you could get them to do a little sit up and you feel into the separation. And if it feels slack and soft, like you can push all the way through, then again, you play with the core contraction cues, see which one gives you the best symmetry of contraction. And then when they do the when they do the curl up, sit up again, they shouldn't be able to push through as far. So you can incorporate those aspects into your training, and then it's just a matter of once you've got a great symmetrical core cue, then you just need to apply it to whatever exercise you're doing, and doing that will help the separation actually heal. Does that answer that question? In a very long-winded way.
I think it does, because it actually leads me to another question. So from the point of view of as a trainer, cueing people doing exercises, yep. I mean, well, there's two sides to it actually. The most obvious exercises that we would try to avoid as trainers then is obviously the jumping, the high impact work. Mm-hmm. And then when we move into a horizontal plane and we start trying to do abdominal work, then for us, I'm presuming you're saying that one of the best cues is actually pelvic stability. So knowing where your pelvis is, and whether when you make those movements, let's say with legs or doing curls, whatever, that pelvis yep. stays in place, because that means yep. then you have your, essentially, if you've got pretty good stability there. But if it's yep. if it's moving around, then there are issues that probably need to be assessed and treated.
So if I tilt the camera down, I'll lie down and I'll show you. So if I was to put my hands like this, I don't want to feel my pelvis roll side to side even a little bit when I'm doing like a leg lift or a leg lift and then you press it long. I should have enough stability in my deep system to hold my pelvis still without arching or flattening or gripping in my butt or my shoulders or my chest. I should just be able to lift my leg using my leg muscles because it's a leg exercise. Really frequently what you'll see is people get their shoulders in, they grip through their whole body, they grip in a wide range of spots to try and stabilize because they haven't got a good symmetrical core contraction. And sometimes people need 2 cues. But what I'll do is I'll run you guys through a list of core cues and you can have a crack at them while you're sitting there. So if we go with the pelvic floor ones first, so you can think about the vagina opening, see if you can squeeze it and lift it up without squeezing your bottom cheeks. So another one would be to think about where your clitoris is and see if you can get it to nod. Most people can't do that, but sometimes that's the one for people. Think about where your anus is and pull it up towards your pubic bone without squeezing your bum muscles. So they're the most common pelvic floor ones, and obviously can you stop peeing halfway through when you're weeing. And you need to be able to keep your inner thighs soft and keep your butt muscles soft. And most people clench their butt when they're trying to turn on their pelvic floor, or they clench their inner thighs. The more you clench your inner thighs to turn on your pelvic floor, the more knee problems and hip problems you're going to have. And again, really commonly with people doing squats and things like that, they just use their inner thighs, and so their butt muscles don't turn on, and so they progressively get more dysfunctional in the pelvic floor. So there are just areas like that you want to keep an eye on. If we go more to cueing your deep system through your stomach, so through your, what we'll think of as your core, you can think of a really low slung belt around your pelvis that's getting tighter and tighter and tighter. You can think of those 2 pelvic bones at the front. So you got one on the right, one on the left, gently pulling together. And then less commonly, you can think of the spot 2 inches south of your belly button and gently draw that towards your spine. They tend to be the most effective ones. For guys, things like imagining you're walking into water and the cold water hits your testicles and they pull up inside your body, or peeing over a fence. For some reason, those things work with guys, or imagining the penis and see if they can get it to lift. So they tend to be the most common cues. I would say maybe like 80% of people who come into the clinic are either a low slung belt or the imagining the pelvic bones and gently pulling them together. Very occasionally you'll get people who have to think of the belt on the left and the bone pulling in on the right, because that's just what their body needs. But the big thing with turning on the core and the pelvic floor properly is your bum shouldn't squeeze, your inner thighs should be relaxed, and your tummy should be relaxed. Most people want to overbrace through their core and through their stomach because they want to feel it. Because if you did a bicep curl, you get to feel it and you get the feedback of your arm moving, so you know you did it, and they want to make sure they're actually doing it. And so they overbrace, and then the trouble is then they pull themselves out of alignment all through their spine. Your core is a submaximal muscle. It should turn on in anticipation of movement. So if you're sitting in a chair, your brain should know ahead of time that you're planning to stand up, turn your core on so it's on for that entire movement. But you never were aware of it turning on. So it shouldn't be a big bracing movement. And the more you brace, then the more you will injure yourself training, because if you're bracing just to lift a leg off the floor or to stand up out of a chair, when you go to lift a weight, you haven't got anything else to recruit from your core. So you start using everything else you've got. You've got leg muscles, shoulder muscles, and people wreck themselves that way. Does that help with that one? Cool. So you should be a soft stomach most commonly. So if I'm just going to kneel. So the place where most women grip is under here. So what you would want to do is stand in a mirror, looking at your belly, and try some of those core cues. And the most movement you should see is low belly. You shouldn't see any sucking in under your rib cage. And for most women, that's really difficult. And they'll really cheat a lot under those upper ribs, and that can cause quite a bit of problem. Any other questions that anyone specifically got?
I'm going to do another one.
Go on.
Go for it.
I just can't stop talking.
Yeah.
A question. How much guidance are mums getting after childbirth about I was going to say, because it's you know, it gets to a point where I guess, I don't know, because obviously I'm not female or a mum, but it must get to a point where you kind of feel like you've stuffed up. You've been, I don't know, you've neglected yourself or whatever, but actually at some point, why isn't there in that maternity system this kind of guidance?
Because generally in the hospitals, the women's health physios have very little training. Most of the times the patients that they see in the hospital, they're only going to see them for 2 to 3 days. And so in that time, generally they're focused on, can the baby hear? Has the baby got normal foot movement? Is mum and bub well? Are wounds healing? Can everybody poop? Okay, you're good to go. And because most women who've delivered vaginally are bleeding at that point, and they're often bleeding for up to 6 weeks, that they're not doing internal checks to see whether people can actually do pelvic floors. Sometimes you will get in hospitals, they check the abdominal separation. The only trouble with that is that sometimes, quite commonly postnatally, because you've literally just popped a baby out and it takes more than 24 hours for your body to snap back into its old shape, they sometimes freak people out about how wide that separation is. And so you can get some panicked mums coming in and saying, the hospital told me I have to come and see you about my separation. And they're so exhausted at that point. And basically all they hear you say is, it's okay, just put this brace on for a couple of weeks and then I'll see you like, you know, in a week or two. And they just go, yeah, okay, great. And then they're so tired, and that kind of takes over. There tends to be a lot of, I think sometimes they're scared to freak people out. And obviously everybody's a little bit different. Like some people, the more information you give them, the more overwhelmed and stressed they get. Whereas other people do really, really well with that. And so sometimes people go into their birthing situation being woefully underprepared. And also, obviously, you know, the birthing process is wildly different. Sometimes things happen and sometimes the shit hits the fan, and births can be quite traumatic for people. And so they can come out of that process being really overwhelmed. And so the people in the hospital might be assisting with that process or dealing with medical issues postnatally. Or even if they were told something, they're so overwhelmed that they just don't retain that information. And there's not enough of a focus on women's health generally. So they really just kind of leave you to it. I know from our perspective, we've tried to advertise and promote awareness and stuff like that. And you're not allowed to advertise things that have the word like sex in them, or pelvic floor, or uterus, or so that can really restrict how much access to knowledge people get. And often, a lot of the time, people find these issues embarrassing and they have to really make themselves vulnerable to talk about them. And so they don't talk amongst their friends. And yet if they talked amongst their friends, they probably find that, you know, like 70% of them had something going on. And so people don't then say, oh, I went to see a women's health therapist, and, you know, until they get more confident with it. And then we do get some patients who are telling every person that they went and saw a physiotherapist for their vagina. So, which is fine, but like it's just a different medical setup. So in France, if you have a baby, you get a government supported 10 sessions at a women's health physio afterwards, which would be very, very nice if that happened here. But here we're not allowed to talk about those things on advertising platforms. So you're really very dependent on word of mouth for women to hear about the existence of women's health physios. And most of the time, by the time I see them, and they're pretty bad usually by the time I see them, they say, I just didn't know that there was such a thing as a women's health physio.
Pip, why are gynecologists and obstetricians not referring their patients to people like you?
Because gynecologists and obstetricians generally, in most cases, do not know how to assess the pelvic floor. They know how to assess your organ position, and they know how to assess your cervix and whether your baby is well, which is all very, very, very important. And they're having a look at you from a medical perspective. But my experience has been generally when we go to conferences and things like that, the physios who present on the pelvic floor then get bombarded by the obstetricians and the gynaes afterwards, who ask them to give them a quick run through on how you palpate the pelvic floor. So I think it's just kind of one of those things that, you know, like we see it all the time with knee specialists. They only look at the knee, and if it's not the knee, they're out. And I just think it's just because you get specialized training in that, and that takes so long to do and is so specialized that they never have a chance to look further afield. And I think it's potentially a flaw in the medical training that they don't teach them to palpate the pelvic floor. Because I know that they don't teach GPs how to do a pain-free pap smear, and they certainly don't teach them how to manage patients when they are finding a pap smear painful. And I know that some of that is about time. Like when you guys have been to your GP, I'm sure you've made an appointment, but you're there for 10 minutes and they're rushing you out the door the entire time. Yeah. So it's really hard to do a great pap smear under those conditions. And it's really hard for the GPs because, you know, that's not necessarily something that's under their control, and it's not something they've been shown how to do. And they're getting, you know, like really big constraints on their time, and it's just tricky. Like it's hard to have an ideal situation. You know, it's hard for physios to have an ideal situation. If you have as much time as is ideal with a patient, then, you know, you don't see as many patients. So it's a tricky one.
Mm-hmm. It's a real balance, isn't it?
Yeah, and I mean, I feel sorry for the GPs and the obstetricians because they don't get to see a lot of the patient. They've got to cover 50 billion things in that 10 minutes, and they've also got to check, you know, your blood pressure and your meds and you're medically well enough, and they've got to give you your referral. You know, it's hard.
Mm. Where I'm surprised is that at the 6-week check that doesn't happen.
So what a 6-week check is if you've had a cesarean, usually they will just check that your wound is healed. And whenever you have any abdominal surgery, they never check if your core is functioning again. And that's what they need to do, because wherever you puncture through the abdominal wall, you will generally have that muscle be to some degree switched off afterwards. And you need that muscle to have the ability to slide. And if there's scar tissue, it can't slide well, and that's when problems arise. If you've had a vaginal birth, a 6-week check will generally involve checking if you had any tearing. And they usually, but not always, do a quick deep internal to see where your cervix is. And then they will generally tell you that you do or don't have a prolapse based on that. But you can't tell if you have a prolapse unless it's called Valsalva, so unless you bear down for at least 5 seconds. And most of the time, obstetricians don't do that, and I don't know why. Again, I think it might be a time thing. It might be a training thing. I don't know. There are obviously some obstetricians, like anything, you get good accountants, bad accountants. So some are better than others, like with anything. And you know, like some patients want you to check more thoroughly and some don't. So there's a little bit of everything. And I think that's kind of why we do our postnatal check, because it's like, basically the way I look at it is when you have your 6-week check with a ob-gynae GP, they are checking that you are medically well, and that's it. And so then we need to step in and check out if your body is functioning well, like are your muscles well, is your alignment good, is your pelvic floor good, are your organs where they should be, is everything rearranging itself as it should be postnatally. But I think the difference is you can't possibly expect one occupation to do it all, but that's why they need to refer. And I think sometimes specialists have been burnt by bad physios before, and I think sometimes that's why they don't. So, or maybe they just don't know that physios do that, because, you know, it's not like physios get trained to do that at uni. So why would they assume that they could refer safely to a physio, you know. So it's a problem with the entire medical field, is why that.
Yeah, and the fact that you're not able to advertise in detail the sort of service.
It's a vicious cycle.
It makes it really difficult for you. Yeah.
Yeah.
Indeed.
Yeah.
You'll have to use the technique we learned about was it W8 for weight? Because the same for us, we can't talk about weight loss.
Yeah, we can't talk about pain either.
Yeah.
So you can't even talk about back pain.
How can you turn that into a numerical
problems
word?
Or something?
Yeah. Fair enough.
When is the earliest postnatally people can come to see you? Is it ever too late to improve your pelvic floor? So in terms of when's the earliest they can come postnatally, really it's entirely up to when you feel emotionally up to the challenge. So the earliest I have seen people when I wasn't working in hospitals and seeing them on the ward the day of or the day after, generally the earliest you will see them is about a week. And usually you're seeing either the people who have severe incontinence at that point, or the ones who are very nervous about their abdominal separation, or ones with blocked milk ducts who are in a lot of pain at that point. But you can come as early as you like. Generally, you are still bleeding for up to 6 weeks, so they might not do a pelvic floor check at that point. Some of that is down to the comfort of the physio. Like some physios just aren't comfortable doing a vaginal assessment if someone's on their period or whatever. I really couldn't care less, as long as, you know, you've got all your bed protected and everything, it doesn't matter. If someone's suffering from really severe incontinence, like postnatally because of damage that's happened when they deliver, you need to check what's going on, whether they're bleeding or not. But pelvic floor aside, there is a ton we can do from day one. So it's really common that women have very poor alignment of their rib cage postnatally. And that can be from life, carrying single-sided school bags, or sitting like this at your desk at work, or from dropping your breast to the baby to feed. And that can have a huge impact on what your stomach looks like and how well it functions. So you can start working on the stomach and the body alignment from any time that someone's ready. Pelvic floor is more about when someone's comfortable, or you wait till they stop bleeding and stitches are out. And then, is it ever too late to improve your pelvic floor? No. Pelvic floor is generally slow to train, to improve. So if you did the same amount of training on a bicep muscle, you would see a lot more change in a bicep really quickly. Pelvic floor tends to be a little bit slower. Some of that is because people's coordination can be really not fantastic, and you don't get the same feedback you get from bicep training, so they don't always know that they're doing it well. They can be really, really deconditioned and very, very weak. Sometimes people cannot turn their pelvic floor on, and some of how much change you can get in your pelvic floor at any given point is down to the quality of the physio. So if you did a pelvic floor exam on me, you would see not a whole lot. I wouldn't be activating very well. And what a traditional women's health physio would do is just try and stick an e-stim in me to use like electrical stimulation to turn the muscle on. And you wouldn't get a lot of change because my pelvic floor is neurologically inhibited by the position of my first rib on the right and my left foot. So that's my alignment has actually changed the way my nerves are firing. And so if you imagine to turn any muscle on in your body, you need these nerves to meet and connect. And because of my alignment, this is happening. And so I'm just not able to turn on my pelvic floor unless I adjust my alignment. And so if your pelvic floor, your women's health therapist is just looking at your pelvic floor and not your entire body and how the whole thing works, then progress can be very frustrating and very, very slow. Because you are not just a pelvic floor, nor are you just a back. The whole thing works together. It came from two cells. Everything is linked. Everything. And it's quite annoyingly complicated sometimes, but you can change it at any point. The question is sometimes how much change you can get at any point. Like there are certainly things we can't necessarily get you a meaningful change. Like if someone has a grade 3 or 4 prolapse, That's structural damage that's happened. We can improve your pelvic floor, we can fit you with a pessary, but we can't undo that damage. And generally a grade 4 prolapse would be a surgical fix. So obviously we can't fix everything, but like you could be 98 and want to work on your continence. And one of my favorite patients is actually 91 and working on her continence and her pelvic floor. So it's not too late, and you can pretty much go whenever. You sometimes start with gymnasts who are not sexually active because their pelvic floor needs to be strong enough to do that. In the same breath, you can work with the 90-year-olds. Would I recommend all women post-baby do a check appointment? Yeah. So basically, I think all women should have a postnatal check with their obstetrician, gynae, or GP to check that they're medically well. Because there can be lots of things like a retained placenta is one thing. So if you've got bleeding beyond 6 weeks, you actually often need to go and get the little tiny bit of placenta scraped off, or you will keep bleeding and be anemic. But yeah, I mean, your body, if you think of pregnancy as like a endurance event that goes for 9 months with a very painful final exam, also an endurance event in itself. Like if you were running a marathon, you would prep for it. So people should be prepping for pregnancy. They should be prepping for birth, and then they need some help coming back afterwards. So basically, yeah, if they've had a baby, they need to be checked. And you do get women who recover really well. And I don't know if they're just a genetic anomaly, but you get a lot of women who have small issues that can be knocked on the head really quickly, that if they get left, they become bigger problems. And you obviously have women who've had more difficulty.
You just touched on the prepping for birth. Is this something that we should be speaking with you about as well?
Yeah, so really, really important if someone is hypermobile, really important. Mm-hmm. So if someone's really flexible, their connective tissue is often softer and more flexy. So we need to be trying to stabilize their joints as early as possible. We need to be getting their pelvic floor good. We need to be talking to them about birthing positions and things like that to try and minimize the damage and the stretch on the tissue. But, like it's harder to fix issues in pregnancy that are made worse by increased loading. So how long you can cope with any issue is kind of a little bit down to how much load your body takes. So if I was out of alignment and then I add a baby on top of it, it makes it so much worse. But if my shape is changing every single week, it makes it much harder to fix, and you're more doing patch repair than if you fix it before they go and get pregnant, or in the early stages of pregnancy when their shape isn't changing as much. Much easier to get rid of issues early and to prevent them having issues. Much easier.
Fantastic. Are there any more questions out there, guys, for Pip? No? All quiet? All done? Okay.
All done.
Given that, excuse me, given that you aren't in a situation where you can readily advertise, obviously referral is key. So if anyone who's looking at this video, just spread the word, make this a topic of conversation. So we're normalizing talking about women's health amongst guys as well as women to women, amongst your friends. This is something that I feel very passionate about, because I believe that it's something that, from a fitness professional's perspective, we all need to know more about so that we can assist people through their lives. So, Pip, the Refresh You crew obviously will be gladly referring people if it's geographically suitable, because there's a few of us here who don't live on the North Shore. I hope we can... Yeah,
we've just had 2 more pop through, sorry. So do they need a referral? No, they can just book. Yep. The only time you would need a referral is if you were coming in on Medicare. So you can only get Medicare physio if you have a treating specialist. So if you had rheumatoid arthritis, you would have a rheumatologist. So you would already have a treating specialist, therefore you would qualify for Medicare, but most people don't. Your physio can let you know whether you qualify, and then you can get rebates on that. And then in terms of what else can be done to help people. So I think really the big message is, like, if you can get a symmetrical core contraction, then whether most women are going to have babies, and this goes for guys as well. You see abdominal separation really commonly in people who train too heavily with their obliques and don't get the balance of abs activating right. So if you look at your Tarzan posters with Alexander Skarsgård, he has like a 12 pack, and you will still see an increased separation between each side. And that's because he's overworked his obliques. But if you can get a really nice symmetrical core contraction, that tissue in the middle of the six-pack muscles should feel like a t-shirt pulled tight when you do a sit-up. If you cannot get that, you are at a hernia risk. Your discs in your back are likely to break down at some point. So even just having a core ultrasound with a physio that knows what they're doing, where they can put the ultrasound on and physically watch which muscles you're turning on when you think you're doing a core contraction, can make a massive difference. And then the other two things would be, if you're leaking or getting any symptoms of heaviness, the earlier you treat that, the better the results. And the second would be, if you have any symptoms of pain, so pain on penetration, difficult periods, recurrent history of UTIs and thrush, is that you kind of asterisk yourself as possibly having gynae issues, and that training can make those issues worse if you don't know if you are in fact high tone. It doesn't mean you can't exercise, but you need to learn how to let go first and to use your pelvic floor while you exercise well, so that you don't get tighter and tighter and tighter, because people can go from having uncomfortable sex to not being able to have sex. And that's a pretty big quality of life issue. So those sorts of things, it's important for people to know that that is pretty common, and we can actually help with that. They're the big ones from my perspective, from a women's health. And for guys, like, it's as simple as, you know, like stretching and moving and stretching your hamstrings can help with erectile dysfunction and general wellness. So there's a big relationship between gum disease and erectile dysfunction, and tight hamstrings and erectile dysfunction. So movement's really important for pelvic wellness, for hip wellness, and for sexual health. Which,
that's fine.
You know, but if you told those guys, if you stretch your hamstrings, you will always be able to get an erection, they'll be like, on it.
Yeah, so, that's true. And most men probably would go, where's the pelvic floor?
Yeah. You
know, is that in the kitchen?
Yeah.
I don't know. You know, so yeah.
It's just all about where nerves run and where blood vessels run, and it's important.
Brilliant.
Any other last questions?
Do some roller now.
On those hamstrings, Richard.
That's right.
Cool. Any other questions? Cool.
Pip, thank you so much for your time.
No dramas.
You've been majorly generous, and look, I'll be talking with the rest of my members. With your permission, could we post this video into our respective members groups with Facebook? Are you okay with that?
No. Yeah, that's fine.
Yeah, you guess so?
Yeah, that's fine.
What about everybody else, guys? Is everyone else on here okay if it just stays within the Refresh You groups?
Yeah. I am.
Okay, cool. Any objectors, just let us know. Okay, fantastic.
So anyone who wanted to get in touch, you can get in touch with us via our website, which is sydneyadvancedphysio.com.au. We're also on Facebook or Instagram. Phone number, if you want it, is 9416-4410. But yeah, Facebook and website is pretty good. But if anyone wants to contact us, you can do that. We can do another one of these if you want one done on back pain, because that's the other thing that we see all day, every day. And that's, again, a fairly poorly understood area.
That'd be really interesting, actually.
We'll take you up on that, Pip, most definitely.
Cool. Yeah. Thank you, Pip. I really enjoyed it. That was great. I could actually talk about
no dramas.
pelvic floor all night. Love it.
So did I.
Very much.
Have a good dinner, everyone.
Better than Bachelors
Fantastic.
in
Have a
Paradise.
fantastic weekend. Pip, thank you very much.
See you all later.
See you,
Be
everybody.
see
Have a
you
great
soon.
weekend.
Thank you.
Bye.
Thank you, Pip. Very
See ya.
interesting. Bye-bye.
Bye.
But a lot of carbs.